Hello, everyone. I'm Mary Beth Marsden, and welcome to GBMC's Ask the Oncologist Expert. And today we're so happy to have joining us Dr. Yen Lee, who is a hematologist oncologist at GBMC and also a Maryland girl. So we're happy to have you with us and answer a lot of the questions that people have for you today.
Thank you so much. I'm happy to be joining you today.
And since you're a relatively new member of the GBMC family, you've been here for a year now, but that's still kind of a newbie. Just tell us a little bit about yourself.
Sure. So I actually grew up in Kansas, but then moved to Maryland in high school. So I went to Centennial High School in Ellicott City, and then I went to the University of Maryland for my undergraduate degrees, and then spent a year at the NIH doing clinical trial research. And then afterwards, I went to Vanderbilt, where I did my medical school internal medicine and hematology oncology training. And I missed Maryland so much in that 10 years that I was away, so I decided to come home and am very, very happy to be here at GBMC.
Great. And you're with of course, the Sandra and Malcolm Berman Cancer Institute at GBMC. And when we talk about hematology and oncology, are we talking about blood cancers?
Yeah, absolutely. I think what I do is see patients with both what are called benign hematology conditions, but also malignant hematology conditions. So certainly, blood cancers are within that category, and within blood cancers, there's certainly a wide number of them that we see and treat here.
About hematology, we're just talking about the study of blood.
Yes, the study and really the treatment of blood disorders, and that can be a wide variety of different things. That's ranging from what are benign, meaning non-cancerous conditions, such as bleeding problems, clotting problems, things where the hemoglobin, which is what forms red blood cells, has abnormalities and can cause a multitude of problems, among others within the bleeding clotting world and the coagulation pathway as well. So I certainly treat those, and then we're also talking about malignant hematology conditions, including leukemias, lymphomas, multiple myeloma, among others.
Leukemia and lymphoma seem to get most of the press, right? I mean, they're the kind of ones that people hear most about, I feel like. What are they? What are the differences between them?
Sure. So the answer I would say is a little bit complicated overall, but what at the baseline, at least, for leukemia and lymphoma, they are both forms of blood cancers. Leukemia specifically refers to white blood cells that are made and produced in the bone marrow, and really abnormalities related to that. There are both what are called chronic forms of leukemia, and then also acute forms of leukemia. When we talk about that, chronic forms of leukemia are ones that are more indolent, meaning they're more slow growing, and some of those patients may be on the spectrum that they can be observed, and then some, may require treatment depending on the severity of the disease. Whereas acute leukemia is certainly thought to be a lot more aggressive and needs more urgent management. And then lymphomas are a category of blood disorders that specifically refers to abnormalities within lymphocytes, which are also a type of white blood cell. And specifically, those are also made in the bone marrow, and then they mature in other organs such as our lymph nodes and also the spleen. And so that's why with lymphomas, typically that presents, with swelling of the lymph nodes, or the spleen becoming enlarged, in addition to some abnormalities in the blood work.
So I guess those terms are often lumped together or put together because of the white blood cell connection.
Correct. And with leukemias, that can be really any type of the white blood cells, but it's really talking about white blood cells that are arrested in more immature states or overproducing even in the mature state, whereas lymphoma specifically is referring to abnormalities of lymphocytes.
Is one more common than the other?
Yeah. So lymphoma is a lot more common than leukemia is. I would say that, if you look at statistics, talking about like breast and prostate cancer, which are about 250,000 of Americans will get that will be diagnosed with that every year. We see about a third of that in the lymphoma population. And then leukemia is less common than that. So it's maybe like a fourth or a fifth of the population of patients who are diagnosed with like breast or prostate cancer. So it's much less common.
So, Dr. Lee, as you know, we've received a lot of questions from people who may have been patients at one time, maybe not of yours, but may have been treated for some blood disorder or blood cancer. And also just people who are interested or may have someone they love who is also being treated. So I want to definitely get to those because everyone kind of wants to hear the answer to their particular question. But the first one is pretty basic and one that I'm sure a lot of people would ask, and that is, what are the symptoms of leukemia and lymphoma, and I guess any other type of very serious blood condition, blood cancer?
Yeah, absolutely. And that's a really great question. And it's something that we, I think, really struggle with defining because, some of these more common types of cancers that we see, such as breast or colon cancer or prostate cancer, there's great screening processes for those. Whereas there's not really great screening and the symptoms that people may experience can be nonspecific. Sometimes it's just picked up on a routine blood test that you see your primary care doctor, you're getting lab work, and you really are not symptomatic. For people who are, when we talk about symptoms, I would say things like, new onset fatigue that is really unexplained, in addition to having night sweats and sometimes fevers, low grade typically, in the 99 to 100 range, that don't seem to have a clear cause. Certainly with lymphomas, you think more about enlarged lymph nodes, and sometimes having weight loss or feeling full really early. So and I don't want to say those. I say all of that with the caveat that if you have any one of those individual or multiple of those individual symptoms, it automatically means that you have a blood cancer or anything like that. But I do think that if you are having any of those symptoms, it's very important to have a conversation with your primary care provider and see if it's an appropriate referral to see a hematology oncologist at that point.
It sounds like blood work is kind of the key. I mean, because that's a pretty easy thing to do.
Right. And I think, if those symptoms are happening, that's one of the easiest tests and most straightforward tests that we can do to look to see if there's any abnormalities there. And then certainly our physical exam is very important. If you do notice a new bump, certainly typically the areas that we are checking for are in the neck, underneath the armpits and kind of in the groin area. So if there's swelling or discomfort that you're noticing in those areas that are worrying you, then it's important to seek care for that.
Is there one age group or gender that is more susceptible to leukemia or lymphoma?
Sure. So I think, unfortunately, they do not discriminate based on gender for sure. But typically, when we are talking about leukemias and lymphomas, they are more common in probably our 60 to 70-year-old patient population. There is, select groups of lymphoma. So within lymphoma, it's typically divided into non-Hodgkin's lymphoma and Hodgkin's lymphoma. And Hodgkin's lymphomas are more common in our younger patients. So our kind of adolescent, young adult patient population. So 20 to 30 to 40-ish year olds. is when we see Hodgkin's more likely, although there are older patients who have Hodgkin's as well. But our typical non-Hodgkin's lymphoma, that is much more seen in the 60 to 70-year-old population. And I shouldn't say similarly, but leukemias are also much more common in the sixth and seventh decade as well.
Is there one type, I think we've often heard of Hodgkin's and non-Hodgkin's, and is there one type that is more easily treatable than the other?
Sure. So Hodgkin's lymphoma makes up about 10% of our lymphoma diagnosis. In general, I think part of it is also it's younger patients that typically get it. It is highly curable. We're talking about cure rates in the 80 to 90% range for patients with Hodgkin's. For non-Hodgkin's lymphoma, it is still curable, but it also depends on the subtype, because now we're talking about over 30 or more subtypes of lymphoma, and depending on the type, those some of them, and we're getting into a little bit more detailed nuances, but there are indolent forms of non-Hodgkin's lymphoma that are treatable, but typically not considered curable, but patients can expect to live a typical life expectancy with that. And so I would say those are I wouldn't say easily treatable, but they are treatable, and conditions that you can live a long time with. And then there are more aggressive forms of non-Hodgkin's lymphoma, and the one that we see the most is diffuse large B-cell lymphoma, and that is counterintuitively, it is curable, but that is typically curable in about 60 to 70% of patients.
So it sounds like, each patient is really individualized.
Absolutely, absolutely. And I think that's part of the reason why leukemia and lymphoma are difficult diseases to talk about, because they are so individualized, and it really depends on, and we have a number, because there's so many different types of diagnoses that we're talking about, it is difficult to kind of lump them into one entity to be like, well, if you have this, then this is X, what I'm expecting in terms of treatment and also in terms of life expectancy. So we do really try to tailor our treatment and discussion about that depending on the disease that they have.
Someone asked, is leukemia genetic?
Sure, that's a great question. So right now, we do not think that leukemia, for the most part, is genetic. There are certain abnormalities that there are certain chromosome abnormalities that you can be born with that make you more prone to developing cancer, with leukemia being one of them. They're relatively rare diseases, though. We're talking about people who are born with bone marrow failure conditions. That's typically the types of things that we're thinking about. And then, having chromosome abnormalities, and trisomy 21 or Down syndrome is the most common, that they are certainly more prone to developing leukemia as well. There are very rare subtypes of inheritable leukemia, but that is something that is usually seen, earlier on in childhood, and those patients are followed closely.
What are and are there long-term effects to children who are cured from their leukemia?
Sure. So, kind of, I guess I didn't address this a little bit earlier, but the most common type of leukemia in the pediatric population, which I think a lot of people know about, is acute lymphoblastic leukemias, or ALL. That is highly curable. It used to not be, and it's been amazing that our pediatric patients can now be cured of this, and with high success rates. I would say, overall, I think we do think about, long-term complications depending on what they needed. If that included a bone marrow transplant, then there are, infectious complications from that, needing to be on medications, immunosuppressive medications long term, things like growth or growth delays, long-term fatigue, thyroid issues, and then certainly, unfortunately, having had cancer, it certainly does put you at increased risk of developing a second malignancy later in life, especially after being exposed to chemotherapy before.
Someone wants to know what are some of the other blood disorders, and I think you've touched on some of them, but there might be a couple that you really want to talk about that you treat people with at GBMC.
Sure. So, even though we're talking a lot about malignant hematology conditions right now, I also treat a lot of benign hematology conditions. And so, one of the most common things is blood clots. And so, that we see a lot of times, after surgery, there may be some family history, there's some trauma, or, now we know with COVID, the risk of blood clots is high. And so, we certainly are seeing patients who have developed blood clots as a result of that. And so I see a lot of patients and help manage a lot of patients with deep vein thromboses, pulmonary emboli, and then there are more rare types of blood clots that I treat as well, like portal vein thromboses, cerebral vein thromboses, things like that. I also treat people on the opposite end of the spectrum where they are bleeding, and so typically that there are some inherited bleeding conditions that people develop, and that is usually in childhood that they're first noticed, although some, in rare cases, they are not noted or do not get referred until they are adults. And so I see a lot of patients with bleeding disorders and do the workup and, talk to them about management of those diseases as well. And certainly the most important thing is during the times of surgery or procedures, how do we manage that? So I see those as well. And then I also see patients who have, things like anemia, which is one of the most common hematologic disorders that we have. And, that can be due to a wide variety of issues, whether that's a bleeding issue, whether that's related to cancer, whether that is because you develop an autoimmune condition where you're destroying your own red blood cells, nutritional deficiencies. There's numerous reasons for that. And so I see patients with that, or, just abnormalities of white blood cell counts or abnormalities in their platelets. I also, am happy to see patients with those issues. And, together we do the workup for that and figure out, what's going on and how we need to manage those.
We just got a couple of questions in live as you're talking, and one is, would an adult/adolescent who has been cured from leukemia as a child be more susceptible to COVID now?
That's a really good question. I don't know that we have the scientific research and the wherewithal to say exactly. The hope is that if you've been cured of that disease, that your immune system has returned to normal because you do not have those abnormal cancerous cells that are present anymore. So I'd like to say that we do not think that you are necessarily at a higher risk, but certainly would encourage you to take the same precautions in general that the CDC and GBMC is recommending. I do think that it's a little bit different if certainly you've been through transplant or you're on immunosuppressive medicines, then then your immune system is certainly not the same, is not expected to be the same. And, we do think that there is a higher risk associated with that.
Someone else wants to know, how long are non-Hodgkin's lymphoma patients typically under treatments like infusion?
Sure, great question. It really depends, again, on the type of non-Hodgkin's lymphoma that you have. There are more indolent types of lymphomas, things like follicular lymphoma or marginal zone or others that, you may not even need to be on treatment. You may be observed for a long time, but if you do need to be on treatment, sometimes those they can be a short course, or it can be a pill that you may need to take for an extended period of time. And then, the more aggressive types of lymphoma, such as diffuse large B cell, the first line therapy, I would say we're talking about 3 to 4 months of infusional treatments. Every 3 weeks is the typical regimen, but that can totally change depending on your individual circumstance. So I don't want that to be like what everyone gets, but that's kind of a more generic answer for the question.
I kind of wanted to follow up with more treatment questions, but I feel like it's going to be really dependent on what that individual is going through. I mean, we hear about bone marrow transplants and that kind of thing, but what is or a couple of the standard treatments that are still being used today?
Right. So I think those are great questions. For lymphoma, I think our mainstay depending on aggressiveness of the disease, the more aggressive forms, we do traditionally think to give chemotherapy. For the more indolent forms of lymphoma, we do try to give targeted therapy if possible. And so that is certainly dependent on the type of disease that the patient may have. But I think that's kind of the best gauge, and talking in more detail, and really depends on the type of disease that they have. I think a lot of people do wonder about transplant and like what role does that play. I think that there is certainly a big role for that in multiple myeloma, which we haven't talked too much about right now. But in terms of leukemia and lymphomas, that is typically reserved for the relapse refractory setting. We would discuss that,
I
and
don't think
also
we've
CAR
talked.
T.
We haven't talked about this, but we had a couple of questions about it. What is von Willebrand's disease?
Sure. So von Willebrand's disease is the most common inherited bleeding disorder that I see from my patients, and it is typically diagnosed in childhood, and also there is usually a family history of von Willebrand's, and so we can do blood testing to figure out if that is in fact the diagnosis, and then we have multiple management strategies for the disease.
Someone, it might have been the same person, wanted to talk about the treatments. You touched on some, but they said they wanted to know about other treatments other or besides a hormonal birth control, which I guess is used in some cases.
Yeah, I think that that has been a strategy that's been employed, usually for bleeding associated, and specifically for women. Part of what you can have with von Willebrand's disease is menorrhagia or heavy periods, and so hormonal birth control can be used to try to slow down the bleeding process. There are other medicines that are employed. Sometimes there's something called tranexamic acid that can also be used for heavy bleeding associated with von Willebrand's. And then there's also other more infusional medications, and those are really more so reserved for procedures. And then for really severe von Willebrand's, there are also infusional products that we give, something called Humate P, and there's others that are similar to that, that is used, as a prophylactic management strategy for severe von Willebrand's, and also for surgical management.
Are there environmental factors that may contribute to blood cancers? For example, does growing up in a house with smokers or a particular diet contribute to blood cancer?
Sure. I think unfortunately secondhand smoking and, if you are a smoker, we do think that that does increase risk for cancer overall. Specifically for leukemia or lymphoma, there is an association, but, I think that that is generally true for most of the cancers that we see overall. Diet-wise, we think, there is some data to suggest that maybe red meat is not, the best, and so avoiding that can certainly decrease risk of cancer, and again, that applies to a lot of different types of cancers as well. Um, Other environmental factors, we think, having radiation, we think certainly having a history of chemotherapy, unfortunately, for any type of disease, is certainly can put you at increased risk for secondary malignancy and specifically for leukemias and lymphomas as well.
You mentioned that we haven't really touched on this, and I guess we probably should. Can you tell us a little bit about multiple myeloma?
Sure. So multiple myeloma often gets grouped in kind of with lymphomas, although the specific cell that is abnormal is a little bit different. So it's a little bit different in the maturation process of a lymphocyte. So multiple myeloma affects what are called plasma cells, and so those are cells that make antibodies. And I try to draw this out for my patients when I see them so that they can understand why we do the blood tests that we do. But what happens in the process of multiple myeloma is that you have an abnormal overproduction of plasma cells, which then overproduces antibodies. And so these are not normal antibodies that you have that help you remember infections and that sort of thing. And protect the immune system. These are antibodies that are abnormal and cancerous. And so when you have an overproduction of these antibodies, these heavy and light chain parts of the antibody, they deposit in multiple parts of the body. And one of those is that it really likes the bones. It can obviously affect the bone marrow where the cells are typically produced. And then it can cause kidney dysfunction, as well. So those patients oftentimes experience bony pain. They can have anemia. Their kidney function can get worse, and also they can develop high calcium levels. And all of those together, in addition to doing, a diagnostic bone marrow biopsy and blood tests, are how we diagnose this, and then the management strategies are chemotherapy based.
Someone was wondering, and it's a good question, if you are seeing an uptick in later stage cancers and disorders due to patients avoiding coming into the hospital, of course, during the pandemic.
Yeah, I think that's been. I have not seen a huge change in that. I do think there has been. The reality with a lot of the diseases that I treat when it comes to leukemia and lymphoma, I think, typically because by the time that I see these patients, they are symptomatic or there's something abnormal in the blood counts. Those are things that I can do relatively easily with blood tests, and also with some imaging studies. And so I find that it has not affected my my clinic dramatically, but I do think that there has been patients in that situation, and it's really unfortunate. So I do want to say that if patients want to be seen, but they are worried or scared for any reason, we offer telemedicine visits, and I think that that's also a very important and integral part of the care that we provide. And so, if there are patients who are hesitating or have been told by their primary care doctor that they need to see a hematology oncologist and are worried about this, we are more than happy to try to accommodate them in any way that we can so that it does not delay their care.
Which leads me to this to sort of wind up our conversation because we are running out of time. I always think it's so wonderful because GBMC is a community hospital first and foremost, and there's a great relationship between the community and the staff. And so there's a way for people to get involved with what you do and with the center at GBMC. How does that happen?
Sure. So for a long time, I think we've had a great and very proactive volunteer program here. Of course, with COVID right now, that's been on hold, certainly. But one of the great things that is happening in the next couple of years is that we are going to be building a new cancer center, and we're very excited about this. And we've gotten some very gracious and amazing donations from the Berman family as well as others that has been very supportive. So I think, right now, donations is a great way. And also we have our oncology support team as part of the GBMC oncology team, really, and they also have potentially some great ideas for patients to be involved and help out as well.
At those at donations is, they're kind of twofold. One is that you can honor someone who's been treated, or you yourself are grateful for the treatment that you've had, but it's also sort of an insurance policy, right, to support a hospital that's near you, that in case you ever need it, will be there and will have the best of the best.
Right, absolutely. I totally agree. And I just want to say I've only been here for a year, but this is an amazing institution. I think we really try to treat our patients like they are a part of our family, and that, it's not just me on the team, it's everyone including my colleagues, including all the nurses, nurse practitioners, and all of our support team that really, we just want the best for our patients, and we want them to feel like, we care about them and want to support them in any way that we can.
Well, Dr. Yen Lee, thank you so much for joining us today and answering everyone's questions. And thanks to everyone who joined us today for GBMC's Ask the Oncologist.
Thank you so much. I appreciate it.